What is going on, wonderful people? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my neurology playlist. In previous videos, we talked about neuroanatomy, neurophysiology, neuropharmacology, and neuropathology. We talked about diseases such as stroke, ischemic and hemorrhagic. We talked about the different types of shock, including neurogenic shock. We talked about the Cushing triad of intracranial hypertension. We talked about hydrocephalus, brain herniation, and idiopathic intracranial hypertension. We talked about multiple sclerosis, which is demyelination of the central nervous system, and Guillain-Barré syndrome, which is demyelination of the peripheral nervous system. We discussed myasthenia gravis and Lambert-Eaton myasthenic syndrome. We talked about poliomyelitis, vertigo, and Meniere's disease. Today, we shall talk about one of the most horrible diseases ever, amyotrophic lateral sclerosis, which causes muscle paralysis and muscle wasting. Click the like button, click the subscribe button, and let's get started. Amyotrophic lateral sclerosis has many names. You can call it amyotrophic lateral sclerosis, or abbreviated as ALS. You can call it motor neuron disease, or Lou Gehrig's disease, or Charcot disease. But why do we call it each one of these names? Let's start by amyotrophic lateral sclerosis. What does A mean? A means no. What does myo mean? Myo means muscle. How about trophic? It means growth. Oh, so there is no muscle growth, which is a nerdy way of saying muscle wasting. Why do we call it lateral? Because it affects these parts of the spinal cord, as you see. What are the names of these tracts? These are the lateral corticospinal tracts, hence the lateral. Why sclerosis? Sclerosis means hardening, as in atherosclerosis, hardening of the vessels, and ALS, which is hardening of the muscles, because these muscles are stiff. They are spastic. Hashtag spastic paralysis. And that's why it's called amyotrophic lateral sclerosis. Why do you call it motor neuron disease? Because it's a disease that affects nerve cells, causing motor deficits, not sensory deficits. Why Lou Gehrig's disease? Lou Gehrig was a famous baseball player in America who suffered from ALS. Why do we call it Charcot disease? Named after the famous neurologist of the 19th century, Jean-Martin Charcot. If I am your patient and you are my neurologist, supposed to take care of me, before I let you do anything, I'm going to ask you one question. What do you know about Jean-Martin Charcot? If your answer is, Jean who? I'm leaving your hospital. I will decline treatment. I would rather succumb to my own psychosomatic neuroses than be treated by a schmuck who does not know who Charcot was. Half of the neurology textbook is named after Charcot, such as Charcot's artery, which is the lenticulostriate artery. Please refer to my video on stroke to learn more. And Charcot joint, which is a disease that happens to patients with diabetes. Charcot disease is ALS, or amyotrophic lateral sclerosis. Charcot-Marie Tooth disease. Charcot-Willebrand disease, which is visual agnosia. The infamous aneurysm of Charcot-Bouchard aneurysm. And for gastroenterologists, there is Charcot triad, which we see in acute cholangitis. Refer to my video on cholecystitis to learn more. There is also the Charcot triad of multiple sclerosis and Charcot-Leyden crystals, which are microscopic crystals made of eosinophilic proteins that we find in patients with asthma or parasitic pneumonia. And that's why I was mad at my neurologist, because I want my personal doctor to know what the French toast he's talking about. If you want to see more videos like this in the future, please drop a brain emoji in the comments. I have two playlists on this channel dealing with neuro. One is called neuroanatomy, and the other is called neurology. Neurology has everything. It has neuroanatomy, neurophysiology, neuropharmacology, and neuropathology. Back to basics, we have central nervous system and peripheral nervous system. The central nervous system is made of brain and spinal cord. That's it. The peripheral nervous system is made of cranial nerves and spinal nerves. So by definition, when I say nerve, it is peripheral. There is only one exception to this. Can you name a nerve that is part of the CNS rather than the PNS? Please comment below. So here's your nervous system. We have central nervous system and peripheral nervous system. Central nervous system, brain and spinal cord. Peripheral nervous system, cranial nerves and spinal nerves. How many cranial nerves do you have? 12 pairs. How many spinal nerves do you have? 31 pairs. I want you to master neurology like it's nobody's business. And to do so, you have to understand the lingo, the language of neurologists. What is encephalopathy? This is pathology of the brain. And by brain, I could mean anything. It could be the cerebrum, it could be the basal ganglia, it could be the midbrain, the pons, the medulla, the cerebellum. Don't care. All of this is encephalopathy. Under encephalopathy, we have subtypes. Let's say that I have inflammation of the brain substance itself. This is called encephalitis. Let's say that their inflammation is just in the cerebrum, not the cerebellum, not the brainstem, not the basal ganglia, just the cerebrum. This is cerebritis. A collection of pus in the brain is brain abscess. If it's in the cerebrum, cerebral abscess to be specific. Inflammation of the meninges that cover the brain and the spinal cord is called meningitis. We're done with the brain. Let's talk about the spinal cord. If the pathology is in the spinal cord itself, it's called myelopathy. If it's inflammation, it's myelitis. If the pathology is in the nerve root as it exits the spinal cord, it's radiculopathy. But if the pathology is in the peripheral nerve, it is peripheral neuropathy. If the pathology is in the muscle, it is myopathy. If the pathology is in a channel, such as a calcium channel or chloride channel or potassium channel, it is a channelopathy. And this is why senior pathologists call me daddy. If you wish to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you want me to personally tutor you, reach out to me on my website. I can tutor the medicine out of you. Quick review of the anatomy of the spinal cord. If you've watched my neuroanatomy playlist, you will recall rule number 1. Thou shalt draw your line in the sand. Anterior is mostly motor, posterior is mostly sensory. And of course, motor is efferent, but sensory is afferent. And because what's good for the goose is good for the gander, the same concept applies to the spinal cord. Anterior is mostly motor, posterior is mostly sensory. For example, this is the anterior horn cell. It has motor functions. But this is the posterior horn. It has sensory functions. Again, motor is efferent, so this is the efferent root, which is ventral root, because we are in front of the line. But the sensory is the afferent, and it's dorsal root, as you see. Then we have a spinal nerve, which is mixed. It has motor, and it has sensory fibers in it. As you see, the spinal cord has gray matter, which has anterior horn, lateral horn, and posterior horn. It also has white matter, which has columns or funiculi. This is the posterior funiculus. These are the lateral funiculi, and these are the anterior funiculi. This is the soma, and this is the axon of your neuron. The soma cannot be myelinated. It's always unmyelinated. And if the soma is unmyelinated, therefore it has to be part of the gray matter, such as this. You find a bunch of somas here, a bunch of somas there, a bunch of somas there. Similarly, in the brain, there is gray matter, but it's on the outside. So what's in the gray matter? A bunch of somas, as you see. This is a soma, and then the axon will be myelinated, and that's why the axon is part of the white matter in the brain. Speaking of axons, some of them are myelinated and they will be part of the white matter. Some of them are not myelinated and they will be part of the gray matter. So the white matter has one thing only, myelinated axons. The gray matter has two things. It has unmyelinated axons and it has somas. To understand what's going on in patients with amyotrophic lateral sclerosis or ALS, we gotta talk about the upper motor neuron and the lower motor neuron. And it goes like this. Suppose that you want to contract your left biceps in order to flex your left elbow. The impulse has to start from the right side of the brain, not the left. Where do I start? In the primary motor cortex of the brain. It's part of the precentral gyrus, in front of the line in the sand, in front of the central sulcus. And then these fibers will descend. We're still on the right side of the brain. We're going to pass through the posterior limb of the internal capsule. And then we are in the midbrain, occupying the crus cerebri or the cerebral peduncle. Then we're going to occupy the basilar part of the pons, basis pontus, which is in the anterior half of the pons. And then we're going to go to the medullary pyramids. In the pyramids of the medulla, we're going to cross to the opposite side, from right to left, for example. This is called the motor decussation or the pyramidal decussation. Now I am on the left half of the body. I'm going to descend here in the spinal cord, occupying the lateral funiculus, hence amyotrophic lateral sclerosis, because this is the lateral corticospinal tract. After this, the neuron will end by synapsing here. So that will be the end of the first neuron, which is the upper motor neuron. And this will be the beginning of the second neuron, which is the lower motor neuron, as you see here, until we reach the biceps, your left biceps to be specific. This lower motor neuron fiber of the musculocutaneous nerve is gonna spit acetylcholine onto the biceps. The biceps will accept that spit, that neurotransmitter, by means of its DUSI receptor known as nicotinic sub-M. This is nicotinic, this is for muscle, a skeletal muscle that is. Let's do it again. You decided to contract your left biceps. So the impulse has to start from the right half of the brain, in the right primary motor cortex, in the right precentral gyrus. And these are the somas. The somas cannot be myelinated, so we're talking gray matter here. Then these axon fibers are myelinated, so they are part of the white matter of the brain. Will occupy the posterior limb of the internal capsule, and then the crus cerebri of the midbrain, the basis pontis of the pons, or the basilar part of the pons, and then will occupy the pyramids of the medulla. We are going to cross in the vicinity of the medulla, hashtag pyramidal decussation, because this is pyramidal tract. Why do you call it pyramidal? Because it occupies the pyramids of the medulla. Recall that your medulla has pyramids and has olives. The pyramids are for the pyramidal tract. The olives are for the extrapyramidal tract. To learn more, please refer to my neuroanatomy playlist. This DUSI upper motor neuron cell is going to cross to the opposite side. From right to left, as you see, we cross in the medulla. Then we'll descend in the spinal cord, occupying the lateral funiculus of white matter, which is the lateral corticospinal tract. Why do you call it cortico? Because I started in the cortex. Why do you call it spinal? Because I'm going to end in the spinal cord. And why do you call it lateral? Because I'm here laterally. And why is it a tract? Because a tract, by definition, is a collection of axons in the central nervous system. Remember that the brain and the spinal cord are part of the central nervous system. The end of this upper motor neuron will be here at the anterior horn cell. It will synapse with the lower motor neuron at the anterior horn cell. This is also known as the primary motor neuron. The first one is upper motor neuron. The second one is lower motor neuron. The first one is a tract because it's part of the CNS. The second one is a nerve because it's part of the PNS. So what's the problem in patients with amyotrophic lateral sclerosis or Lou Gehrig's disease? The problem is that the upper motor neuron is destroyed, hence the name lateral sclerosis. And if that was not enough, the lower motor neuron is also destroyed, hence the name motor neuron disease. What are the signs and symptoms of upper motor neuron lesion? And what are the signs and symptoms of lower motor neuron lesion? Upper motor neuron, it's hyper positive, but lower motor neuron, it's hypo negative. Upper motor neuron, hypertonia, hyperreflexia, positive Babinski. Everything is up. Reflexes, up. They are heightened. The tone, up. Even the toes are fanning up. But in lower motor neuron, it's hypo negative. Everything is down. The reflexes, down. The tone, down. And even the toes are curling down. Upper motor neuron lesion usually has spastic paresis. Because of the spasticity, this disease is known as lateral sclerosis. Sclerosis from the stiffening. Lower motor neuron lesion causes flaccid paralysis. Both cause muscle weakness. In upper motor neuron, there is no atrophy, no fasciculations. Lower motor neuron, there is atrophy and fasciculation. So what's going to happen in patients with amyotrophic lateral sclerosis? The answer is a mixture of all of these. These are the diseases that cause muscle weakness. Why do I have muscle weakness? We're not talking about general fatigue as in anemia, but we're specifically talking about muscle weakness. Here are the possibilities. The problem could be in the anterior horn cell of the spinal cord. We see this in patients with poliomyelitis, spinal muscular atrophy, and today's topic, amyotrophic lateral sclerosis. If the problem is in the nerve root, it is radiculopathy. Guillain-Barré syndrome does that. If the problem is in the peripheral nerve, this is peripheral neuropathy. Guillain-Barré syndrome also does this. Don't forget diabetes. Alcohol can also destroy peripheral nerves, hypothyroidism, uremia from renal failure, and much more. Then we have diseases of the neuromuscular junction. These include myasthenia gravis and Lambert-Eaton myasthenic syndrome. Then we have the muscular dystrophies, including Duchenne muscular dystrophy and Becker's muscular dystrophy. Metabolic myopathies are many. A famous one is McArdle disease, which is a glycogen storage disease. Congenital myopathies are many, and they include the inherited mitochondrial disorders. Does anyone remember the ragged red fibers? So what disease is this? What's the name of the disease that destroys both lateral corticospinal tracts in both lateral funiculi of the white matter of the spinal cord and also destroys the anterior horn cell on both sides? The answer is, this is Amyotrophic Lateral Sclerosis or Lou Gehrig's disease. It's an upper motor neuron lesion and a lower motor neuron lesion. This is ALS. It has upper motor neuron lesion on both sides and lower motor neuron lesion on both sides. And that's why this disease can lead to quadriplegia. Here is everything you need to know about ALS in one slide. ALS or Lou Gehrig's disease or motor neuron disease or Charcot disease is a neurodegenerative disease where there is degeneration of my nervous system, upper and lower motor neurons. It is also a neuromuscular disease because I have muscle weakness caused by a neurological problem. It can happen in males and females. It's relatively more common in males than females, with a male to female ratio of 1.8 to 1. The typical patient is between 50 and 70. That's usually when the disease is diagnosed for the first time. There is a very important distinction in pathology that you need to be familiar with. There are sporadic cases and the opposite, which is familial cases. What is the difference? Sporadic means it happened to me out of the blue. The disease does not run in my family. My father does not have it, my uncle does not have it, mother does not have it, grandma does not have it, cousins do not have it, no one in the family has it, and I am the first one to get it. It just happened suddenly, out of the blue. It happened sporadically. Contrast that with familial diseases, meaning a disease that runs in the family, and the genetic mutation will be passed down the generations. Most patients with ALS have the sporadic form. About 10% of cases have the familial form. There are many mutations associated with this disease. One famous mutation is the C9orf72. What the French toast does that even mean? This enigma code means that the problem is on chromosome 9, that's where the genetic mutation is, and it's an open reading frame 72. This explains a big chunk of cases. There is another one, which is the superoxide dismutase or SOD1. This is an enzyme mutation, and this is a very high yield fact for board exams. To help my students remember that ALS is associated with the SOD mutation, I have a terrible and inappropriate mnemonic. Viewer discretion is advisable. Are you ready? Okay, my dear student, do you think that ALS is a benign disease or a terrible disease? Of course it's a terrible disease. I mean, it's upper motor neuron lesion and lower motor neuron lesion, and it's horrible, it's terrible. That's right. So it's as if that the patient was metaphorically sodomized by fate. Next, the prevalence of ALS is about 5 cases per 100,000 population. Signs and symptoms and physical exam findings of ALS. We have upper motor neuron lesion and lower motor neuron lesion. Because I have upper motor neuron lesion, we have hyper positive, hypertonia and clonus, hyperreflexia and positive Babinski. And I have lower motor neuron lesion, hypotonia or atonia, no tone, hyporeflexia or areflexia, and negative Babinski. Upper motor neuron lesion, spastic paresis, the muscles are stiff. Lower motor neuron lesion, flaccid paralysis, the muscles are soft. Upper motor neuron lesion can lead to loss of fine motor dexterity. Lower motor neuron lesion can lead to fasciculations, including tongue fasciculations. But there are some intact findings in ALS. The extraocular muscle movement is fine. The bowel function is intact. Bladder function is intact. And notice that ALS is a purely motor disease, not a sensory disease. So the sensations are intact. Can a male patient with ALS have erections and ejaculations? The answer is yes, because these are autonomic functions and not somatic motor functions. Remember that the autonomic spinal nerves live through the lateral horn cells, not the anterior horn cells. See, medicine makes so much sense once you understand what the French toast you're talking about. One of the skeletal muscles in your body is the diaphragm, so it can be affected in ALS, leading to respiratory paralysis and respiratory insufficiency. This is a restrictive lung disease. Is it extrinsic restrictive or intrinsic restrictive? It is extrinsic restrictive lung disease. To learn about the difference, please refer to my pulmonology playlist. These patients can have bulbar symptoms and pseudobulbar symptoms. What is the bulb? The bulb is the brainstem, okay? The brainstem has the origin of most of your cranial nerves. It's the 3rd, the 4th, the 5th, the 6th, the 7th, the 8th, the 9th, the 10th, the 11th, and the 12th. Cranial nerves. Basically, all of the cranial nerves except the first two. Cranial nerves 3 to 12 leave the brainstem. And what do? They reach muscles and skin of the face and the neck. So head and neck, basically. So symptoms that can happen when I destroy my brainstem include dysarthria and dysphagia. Dysarthria cannot talk or cannot articulate. Dysphagia cannot swallow. I told my students that bulbar symptoms are the 3 Ds: diplopia, dysarthria, dysphagia. But in ALS, usually there is no diplopia because the extraocular muscles are usually intact. Next, because ALS can affect the brain, especially the cerebral cortex, which has executive function, ALS patients can have diminished executive functions. Next, inappropriate laughter or inappropriate crying. These are the pseudo-bulbar symptoms. So if you find yourself laughing at my dad jokes, maybe, just maybe, you need to get yourself checked for ALS. How can we diagnose ALS? Clinically, as you see, signs and symptoms, electromyography. There was an old song by Dr. John Baroon, and it went like this: Amyotrophic Lateral Sclerosis. EMG will clinch the diagnosis. Loss of both upper and lower motor neurons, etc., etc., etc. Superoxide dismutase. Gene mutation, just a trace in this case. This song has disappeared from the surface of the internet for an unknown reason. MRI, not to diagnose ALS, but to rule out other conditions such as tumors, such as multiple sclerosis, etc. Pulmonary function tests for the respiratory paralysis. This is an extrinsic restrictive lung disease. Genetic testing to find the gene mutations. These mutations could happen sporadically or in a familial fashion. Treatment for the respiratory paralysis, you have the BiPAP and respiratory support and physical therapy. Severe progressed cases might need ventilatory support. Riluzole is a glutamate antagonist that can help some patients with ALS. Another drug is edaravone, which decreases the physical deterioration seen in ALS. For the spasticity, because of upper motor neuron lesion, you can give baclofen, you can give clonazepam, you can give tizanidine. What's the mechanism of action of baclofen? What's the mechanism of action of clonazepam? And what's the mechanism of action of tizanidine? If you know the answer to these questions, please comment below. For the pseudo-bulbar symptoms, such as the inappropriate laughter, there are antidepressants that might help. Dextromethorphan quinine can also help. Quiz time. Here's a question for you. What is the differential diagnosis for ALS? If you know the answer, please comment below. Don't forget to take a look at my neuroanatomy playlist. If you want to learn about strokes, myocardial infarctions, cardiac arrhythmias, ARDS, acute limb ischemia, hypothermia, hyperthermia, drowning, and toxidromes, download my emergency medicine high yields course at medicosisperfectionalis.com. My courses come with videos, notes, and cases. To learn about neurosurgery, cardiothoracic surgery, trauma surgery, orthopedic surgery, gastrointestinal surgery, pre-operative care, post-operative care, and more, download my surgery high yields course. To learn about the anti-epileptics, antidepressants, antipsychotics, anti-Parkinsonian agents, the opioids, the anesthetics, the stimulants, and the sedatives and hypnotics, download my neuropharmacology course at medicosisperfectionalis.com. If you value what I do, help me make more videos by supporting the channel. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.